Bismillahirrahmanirrahim. Today lecture is about myocardial infarction and first the ischemic heart disease and ischemia. What is ischemia? Ischemia refers to a lack of oxygen due to inadequate perfusion of the myocardium, which cause an imbalance between oxygen supply and demand. There is imbalance between the supply and demand. The most common cause of myocardial ischemia is obstructive atherosclerotic disease of the epicardial coronary artery. This is a normal artery, and here the plaque formation is in the initial stage, and here the plaque has fully developed, which obstruct the supply of blood to the myocardium or myocardial muscles, which cause less oxygen supply to the myocardial muscle and cause damage. This damage is called myocardial infarction. Myocardial infarction, colloquially known as heart attack, is caused by a decrease or complete cessation of blood flow to a portion of the myocardium. Myocardial infarction may be silent and go undetected, or it could be a catastrophic event leading to hemodynamic deterioration and sudden death. Most myocardial infarctions are due to underlying coronary artery disease. The leading cause of death in the United States are reliable data. IHD, ischemic heart disease, is likely to become the most common cause of death worldwide by 2020. In 2020, ischemic heart disease was the most common cause of death. Etiology of myocardial infarction. INTERHEART is an international multi-center case control study which delineates the following modifiable risk factor for coronary heart disease: smoking, abnormal lipid profile, blood apolipoprotein raise, apolipoprotein B and apolipoprotein A1, hypertension, increased blood pressure, diabetes mellitus, abnormal obesity, waist and hip ratio greater than 0.90 for males and greater than 0.85 for female. Etiology. The major risk factor for atherosclerosis is high plasma low density lipoprotein LDL. When there is high level of low density lipoprotein and low plasma high density lipoprotein HDL. When the LDL is high and HDL is low, this is the major risk factor for atherosclerosis. Psychological factors such as depression, loss of locus control. Loss of locus control means loss of sport game, may feel depressed or anxious. Global stress, financial stress, and life event including marital separation, job loss, and family conflicts. Lack of daily consumption of fruit or vegetable, lack of physical activity, alcohol consumption. This is a weaker association because some researchers think that alcohol protects the heart or reduce the risk of coronary artery atherosclerosis in low quantity. Other risk factors include a moderately high level of plasma homocysteine. Homocysteine is a type of amino acid which the body naturally produces. By at high level, it can damage the lining of arteries. It can encourage blood clotting. This may raise risk of coronary artery disease, heart attack, blood clots, and stroke, which is an independent risk factor for myocardial infarction. Homocysteine is a independent risk factor for myocardial infarction. Elevated plasma homocysteine is potentially modifiable and can be treated with folic acid, vitamin B6, and vitamin B12. Use of these three vitamins can lower the concentration of homocysteine. Some non-modifiable risk factors for myocardial infarction include advanced age, male gender. Male tend to have myocardial infarction earlier in life. Genetic factor, there is an increased risk of myocardial infarction if a first degree relative has a history of cardiovascular event before the age of 50. Epidemiology. The most common cause of death and disability in the Western world and worldwide is coronary artery disease. Based on 2015 mortality data from the National Health Interview Survey, NHIS and CDC, MI mortality was 114,023 and MI mentioned mortality. Based on the atherosclerosis risk in community study ARIC performed by National Heart, Lung and Blood Institute, collected between 2005 and 2014. The estimated annual incidence is 6 lakh and 5,000 new MI and 2 lakhs recurrent MIs. The ARIC study also found that the average age at first MI is 65.6 years, 65 years and 6 months for male and 72 years for female. Pathology of myocardial infarction. The acute occlusion of one of the multiple large epicardial coronary artery for more than 20 to 40 minutes can lead to acute myocardial infarction. The occlusion is usually thrombotic and due to rupture of plaque formed in the coronary arteries. The occlusion leads to a lack of oxygen in the myocardium, which results in sarcolemmal disruption and myofibril relaxation. These changes are one of the first ultrastructural change in the process of MI, which are followed by mitochondrial alteration. The prolonged ischemia ultimately result in liquefacive necrosis of myocardial tissue. The necrosis spread from subendocardium to subepicardium. The subepicardium is believed to have increased collateral circulation, which delay its death. The infarcted area heals by scar formation, and often the heart is remodeled, characterized by dilation, segmental hypertrophy of the remaining viable tissue, and cardiac dysfunction. Evaluation. The three components in the evaluation of myocardial infarction are clinical feature, ECG finding, and cardiac biomarker. ECG, it should be obtained within 10 minutes of the patient arrival in the emergency department. Acute MI is often associated with dynamic changes in the ECG waveform. Serial ECG monitoring can provide important clue to the diagnosis if the initial ECG is not diagnostic at initial presentation. Serial of continuous ECG recording may help determine reperfusion or re-occlusion status. A large and Prompt reduction in ST segment elevation is usually seen in reperfusion. What does a heart attack feel like? Many people feel pain in their chest during heart attack. It can feel like discomfort, squeezing, or heaviness, or it can feel like crushing pain. It may start in chest and spread or radiate to other area like left arm or both arms, shoulder, neck, jaw, back, or down towards your waist. People often think they are having indigestion or heartburn when they are actually having a heart attack. Some people only experience shortness of breath. What are the symptoms of a heart attack? Heart attack symptoms that people describe most often include chest pain, which is also called angina, shortness of breath or trouble breathing, trouble sleep, insomnia, nausea or stomach discomfort, heart palpitation, anxiety or a feeling of impending doom, feeling lightheadedness, dizziness, or passing out. Causes of myocardial infarction. Most heart attacks happen because of blockage if one of the blood vessels that supply heart. Most often this occurs because of plaque, a sticky substance that can build up on the inside of arteries. That buildup is called atherosclerosis. Here you can see that there is building up or deposition of lipid, and this deposition is called atherosclerosis. When there's a large amount of this atherosclerotic building up in the blood vessel of the heart, this is called coronary or heart disease. Sometimes plaque deposit inside the coronary artery can rupture and a blood clot can get stuck where the rupture happened. If the clot blocks the artery, this can deprive the heart muscle of the blood and cause a heart attack. Coronary artery spasm. A coronary artery spasm is a quick tightness of the blood vessel that deliver blood to heart muscle. These spasms may cause chest pain or may not feel any symptom. Here you can see this is the normal vessel, and here spasm has occurred which decrease the caliber of the vessel. Coronary spasm often occur late at night or early in the morning. Treatment focus on relieving chest pain and preventing spasm. The spasm doesn't usually last long and may not even notice them, but they can increase risk of heart attack and other heart complications. Vasospastic angina can often happen at resting. Conductance vessel can cause severe ischemia in prinzmetal angina. Complication of heart attack. Complications associated with heart attack include arrhythmias, abnormal heart rhythm, heart failure, heart valve problem, stroke, sudden cardiac arrest, depression and anxiety, cardiogenic shock, mechanical complication of a heart attack such as ventricular septal defect or free wall rupture. What tests will be done to diagnose a heart attack? Physical examination. Check pulse, blood oxygen level and blood pressure, and listen heart and lung sound. Ask about symptom patient experienced? Asked someone who was with the patient. Test done to diagnose a heart attack. Blood test. One of the most reliable way to diagnose a heart attack is to check for the cardiac troponin, troponin 1 and T in blood. The rising and or falling pattern of the cardiac troponin CTN value with at least one value above the 99th percentile of the upper reference limit URL associated with symptom of myocardial ischemia would indicate an acute myocardial infarction. During a heart attack, the damage to the heart muscle cell always causes this chemical maker to appear in bloodstream. Electrocardiogram ECG. This is one of the first tests you get when you come to an emergency room with heart attack symptom. Heart electrical signal can help tell if an injury is occurring as well as if there are any rhythm abnormalities. Echocardiogram. Using ultrasound high frequency sound wave and echocardiogram generate a picture of the inside and outside of the heart. It shows how well heart is squeezing and how well the valves are working. Coronary angiogram or heart catheterization. This is procedure that use X-ray and contrast dye to show the blood vessel to heart and can help determine if there are any blockage. Heart computed tomography CT scan. This creates a highly detailed scan of heart and its blood vessel to show if there is any significant narrowing or hardening of the major coronary arteries. Heart MRI, magnetic resonance imaging. This test uses a powerful magnetic field and computer processing to create an image of heart. It can show problem with the blood vessel if the arteries to the heart. Exercise stress test. This test can use an ECG, echocardiogram, or nuclear scan while physically active to help show if heart is receiving enough blood flow. Nuclear heart scan. These can use a radioactive dye a provider inject into blood and computer enhanced method like computed tomography CT to find area of heart that aren't receiving as much blood or injured. These can be single photo emission computed tomography scan or positron emission tomography PET scan. Treatment management of acute myocardial infarction. Reperfusion therapy is indicated in all patients with symptom of ischemia of less than 12-hour duration and persistent ST segment elevation. Primary percutaneous coronary intervention PCI is performed to fibrinolysis if the procedure can be performed less than 120 minutes of ECG diagnosis. If there is no immediate option of PCI, it means less than 120 minutes, fibrinolysis should be started within 10 minutes of STEMI after ruling out contraindication. There are some contraindication to these fibrinolytic drugs, so they may be ruled out. If transfer to a PCI center is possible in 60 to 9 minutes after a bolus of fibrinolytic agent and patient meets reperfusion criteria, a routine PCI can be done or rescue PCI can be planned. If fibrinolysis is planned, it should be carried out with fibrin-specific agents such as tenacitipase, alteplase, or retiplase. Relief of pain. The chest pain due to myocardial infarction is associated with arousal, which cause vasoconstriction and increased workload for the ischemic heart. Intravenous opioid, for example morphine, are the analgesics most commonly used for the pain relief. Morphine may be associated with highest risk of death and adverse clinical outcomes. A mild anxiolytic, usually benzodiazepine, may be considered in very anxious patients. Supplemental oxygen is indicated in patients with hypoxia. Nitrates. Intravenous nitrates are more effective than sublingual nitrate with regard to symptom relief and regression of ST depression. The dose is titrated upward until symptoms are relieved. Blood pressure is normalized in hypertensive patients, or side effects such as headache and hypotension are noted. Isocate 1 mg per ml concentration per solution for injection or infusion. The active ingredient of isocate is isosorbide dinitrate. Streptokinase. Streptokinase is a thrombolytic medication activating plasminogen by non-enzymatic mechanism. As a medication, it is used to break down clots in some cases of myocardial infarction, heart attack, pulmonary embolism, and atrial thromboembolism. The type of heart attack, it is used in an ST elevation myocardial infarction. STEMI, it is given by injection into a vein. A percutaneous coronary intervention is not available within 90 to 120 minutes of first contact. Streptokinase is recommended intravenously as soon as possible after the onset of ST elevation myocardial infarction. Beta blockers. This group of drugs reduce myocardial oxygen consumption by lowering heart rate, blood pressure, and myocardial contractility. They block beta receptor in the body, including the heart, and reduce the effect of circulating catecholamine. Beta blocker should not be used in suspected coronary vasospasm. Platelet inhibition. Aspirin is recommended in both STEMI and non-STEMI in an oral loading dose of 150 to 300 mg non-enteric coated formulation and a maintenance dose of 75 to 100 mg per day long term regardless of treatment strategy. Aspirin inhibits thromboxane A2 producing throughout the life's platelet. P2Y12 inhibitors. Most P2Y12 inhibitors are indicative producing except for ticagrelor, which is an oral active drug that does not require activation. That require oxidation by hepatic cytochrome P450 system to generate an active metabolite which selectively inhibit P2Y12 receptor irreversibly. Ticagrelor is available in active form while the other two are converted into active form by the liver. Inhibition of P2Y2 receptor leads to inhibition of ATP-induced platelet aggregation. The commonly used P2Y12 inhibitors are clopidogrel, prasugrel, and ticagrelor. The loading dose per clopidogrel is 300 to 600 milligram loading dose followed by 75 milligram per day. Prasugrel 60 milligram loading dose and 10 milligram per day of a maintenance dose have a faster onset when compared to clopidogrel. Patient going under PCI should be treated with dual antiplatelet therapy, aspirin and P2Y12 inhibitor, and a parenteral anticoagulant. In PCI, the use of prasugrel or ticagrelor is found to superior to clopidogrel. Aspirin and clopidogrel are also found to decrease the number of ischemic events in non-STEMI and UA, unstable angina. The anticoagulant used during PCI are infraction heparin, enoxaparin, and bivalirudin. Angiomax, the trade name of bivalirudin is Angiomax, is a reversible direct thrombin inhibitor used to prevent blood clot in people with severe chest pain or other condition undergoing a procedure called angioplasty to open blocked arteries. Bivalirudin is recommended during primary PCI if the patient has heparin-induced thrombocytopenia. Streptokinase is used to dissolve blood clot that have formed in the blood vessel. It is used immediately after symptom of the heart attack occurring to improve patient survival. This medication may also be used to treat blood clot in lung, pulmonary embolism, and in leg deep vein thrombosis. Long-term management. Lipid lowering treatment. It is recommended to start high intensity statins that reduce low density lipoprotein and stabilize atherosclerosis plaque. High density lipoprotein are found to be protective. Antithrombotic therapy. Aspirin is recommended lifelong, and the addition of another agent depending on the therapeutic procedure done, such as PCI with stent placement. ACE inhibitors are recommended in patients with systolic left ventricular dysfunction or heart failure, hypertension, or diabetes. Long-term treatment. Beta blockers are recommended in patients with left ventricular ejection fraction less than 40% if no other contraindication are present. Antihypertensive therapy can maintain a blood pressure goal of less than 140/90 mm of mercury. Mineralocorticoid receptor antagonist therapy is recommended in a patient with left ventricular dysfunction, left ventricular ejection fraction less than 40%. Glucose lowering therapy in people with diabetes to achieve current blood sugar goal. Life modification. Smoking cessation is the most cost-effective secondary measure to prevent MI. Smoking has a prothrombotic effect which has a strong association with atherosclerosis and myocardial infarction. Diet, alcohol, and weight control. A diet low in saturated fatty acids with a focus on whole grain products, vegetable, fruit, and fish is considered cardioprotective. The target level for Body weight is body mass index, about 20 to 25 kg per meter square, and waist circumference of 94 centimeter for the men and 80 and less than 80 centimeter for the female. Less than 94 and less than 80, male and female. Prognosis. Despite many advances in the treatment, acute MI still carry a mortality rate of 5 to 30%. The majority of deaths occur prior to arrival to the hospital. In addition, within the first year after an MI, there is an additional mortality rate of 5% to 12%. Though all prognosis depend on the extent of heart muscle damage and ejection fraction. Patients with preserved left ventricular function tend to have good outcome. Factors that worsen prognosis include diabetes, advanced age, delayed reperfusion, low ejection fraction, presence of congestive heart failure, elevation in C reactive protein and B type natriuretic peptide BNP level, and depression. Enhancing healthcare team outcome. The diagnosis and management of patients with ischemic heart disease are best done with an interprofessional team. In most hospitals, there are cardiology teams that are dedicated to the management of these patients. For patients who present with chest pain, the key to the management of MI is time to treatment. Thus, healthcare professionals, including nurses who work in emergency department, must be familiar with the symptom of MI and the importance of rapid triage. A cardiology consultant should be made immediately to ensure that the patient gets treated within the time frame recommendation. Because MI can be associated with several serious complications, these patients are best managed in ICU setting, intensive care unit. There is no cure for ischemic heart disease and all treatment are symptom oriented. The key to improve outcome is to prevent coronary artery disease. The primary care provider and nurse practitioner should educate the patient on the benefit of healthy diet, the importance of controlling blood pressure and diabetes, exercising regularly, discontinuing smoking, maintaining healthy body weight, and remaining compliant with medication. The pharmacist should educate the patient on type of medication used to treat ischemic heart disease, their benefit and potential adverse effect. Only through such a team approach can reduce the morbidity and mortality of myocardial infarction to be lower. Thank you. Please subscribe the channel. Down the bell icon for upcoming update.